In this world, they now have to tell everybody about CDPAP. They have to tell them, it is the law. They must come in and explain. But the difference of this is they also have to explain that they do not have to have care management. They do not have to have it, but the word should be, we're here to assist. If you would like this, we're always here to help. But it is not mandatory for anybody who decides to go on the CDPAP route with the managed care organization. So once they start using that word mandate, or that you need to do this and things of that sort, that's where they've crossed the line, because it is not required. And it does say that also in the register when this law did come into effect. This is not a mandate that they have to have care management, and the health plans do know that. The other piece of this is, though, on the side for why I think that care management is important, is this is the first time too that you will be hiring your own personal attendants. You have to make sure that they meet the criteria. Are they competent? Health plan care managers do know that. So the recommendation is, why not try it out in the beginning if you want? And again, it's not mandatory, but use this person as a guide. Because sometimes in this world, we may not know everything that is important for that home health aide or their personal care attendant that's coming into that home. Or are they doing the right thing? Or the other piece of that is, how do I get in to see a physician the same day? Sometimes we don't know how to do that. So a care manager can help you do something of that sort, because with this population, we do not want them to go to the hospital. And as a nurse, and that's the first time that I look at something like this, I just want to explain why it's not, because everybody always thinks it's money, and that the health plans are against us, and they're doing all these things because of this. Now, when you have this population that has been in the community for a long period of time, the minute that we introduce them to the hospital, believe it or not, that's when you get repeat admissions, because they've been exposed to the environment of things that they've never been exposed to before. And I always say it's better for this population, along with other populations, to stay in their own dirt, because believe it or not, our bodies know that environment better than, believe it or not, what we call the dirt of the emergency room. We share the wealth. So with care management, let's say we're at home and we've been having a cold, but we can't get an appointment for the physician for 2 weeks. A care manager could really push that issue for you to get the same-day appointment, get same-day access. Going back a little, as much as when you're doing a survey about the health plan, it's always access to care. And that's important to health plans, to access to care. So when you're doing these things, sometimes you do need the care manager. So am I saying, recommending to have the care manager there all the time? No. Come into your home and follow through? No. But I am recommending that you do say, I want care management there as my guide. Now, I don't know who's here from the health plans or from that end of it, or from the home agencies or whoever, but there is a recommendation. This is new to everybody. This is meaning to this extent, because remember, we didn't really have mandates before where we had to go out and talk about it. We had to do these things. So when you're doing something new, my recommendation is 6 months, do a collaboration. And the collaboration would be with the health plan and the personal attendance that the family has chosen with the patient, to come to a room together and voice how this has been better, what you can improve on, what the communication has been. These are better ways versus, you know, this isn't working, that's not working. Because I always say to care managers, you know what, you can come back and tell me something's not working, but you better come back and tell me what the plan is and a suggestion. And that's when you have a room full of knowledge from the consumer also, because remember, we're not there. We don't know as the care manager, and this would be a great time to fill the room with the consumer, with the personal attendance of the consumer, along with the health plan, because we always want to do things better. Disease processes. I always tell in the CDPAP world to care managers, because remember, no matter what, you're going to see a care manager for your assessment, because you're going to have to be reassessed. I believe it's every year now in this program. So to make sure that you meet the criteria for Medicaid, so when they're in there and they're explaining. You always want to know what's going on in your community. So you might say to the care man, I don't want to see you, but can I have a phone call from the social worker? Because social workers know everything that's going on in the community. And why would that be important? Well, let's talk about diabetes or medications, or let's say that you need to know something about hypertension. You want to know what's in the community because, again, when you collaborate for things of that sort, you can find out a lot of information. A lot of the health plans do offer group, and they also offer programs, Meet Your Care Manager. And at that time, they invite the vendors that are in their network, because the vendors always want to know what they're doing better. So my recommendation is, meaning I could go on for hours and hours of what care management is. It is a wonderful, wonderful person to have within the health plan, because believe it or not, they become the liaison. And when you do this properly and you have great care managers, you can really get better access to care, get what you need from the vendor, but at the same time, you can stay well in your home. So that is the recommendation, to always use them as a guide. But remember one thing, when they walk in the door, it's not mandatory. Okay, they don't have to come in and check you. They don't, you don't want skilled nursing in there. You don't have to have skilled nursing in there. You want the family to do whatever. My last recommendation is, please, the care plan. And that's required for the care manager, even though you're going to do the CDPAP, that you're going to also review together as a team, that this care plan is sufficient for you, but also that the health plan does know your needs, because remember, you always want them to know what is needed within the benefits so that they're prepared. So when let's say the personal care attendant or your primary care person can't get something, this is your contact person to get it. So I always recommend that you go over the care plan together. So I'm going to let you do whatever you need to do, because I've done enough talking, unless anybody has questions.
I'm Brian Cruz, and I've been on CDPAP for since 1999. I was the first person in Suffolk County with RECO to go on. I was the first person in Suffolk County on CDPAP, and I've been thriving on it ever since. So I approach things from my own experience level, and I had a lot of independence and life prior, and education and knowledge. So I can certainly understand the points that Mary's making, as long as it's not mandatory, because I like to feel that CDPAP people are kind of like the general population with added services. They pretty much run their own lives in every aspect. And, that's why they're on it. Now, I run everything myself. It's a business. Basically, it's my job. I don't get paid money for it. I get my freedom, and I get somebody to be with me all the time. As you can see, I'm pretty severely disabled, but my head is clear and my conscience is able to run my total gamut of necessities. And I think people want help with that. I don't think they want to be governed by it so much. Because, you go back to traditional care and all of the restrictions that it had. And, back in maybe 1990, I had a first meeting with DSS person, head of DSS in Suffolk. And we talked about the mandate that this program needed to exist and how it was someday going to be put into service. And we had many disagreements over what kind of control and what was proper and improper for people to do and go, and that was really why we left it in the first place, because we want to run our own lives. And we partner with the healthcare agency, who's always there to help us. Recco has been amazing with me all of these years, and we're a true partnership. We do everything, we talk about everything, and but when it comes to hiring people, I have got years and years of experience in that. Some people may not. And so in that regard, sure, the show me the ropes kind of thing is not a bad idea at all. But I'd like to see people like myself get involved in this process because, I understand the education and the RN, and all of that educational technicality. I understand all that and I respect it, believe me. Many healthcare professionals have saved my life over the course of 30 years, 40 years. And I understand and appreciate that, their knowledge. But ultimately, I think that somebody like myself and many others like me who've been on the program for years could help individuals in those processes where, so I could speak to someone who could have access to me and say, well, I need to know how to do this a little better. The aid from the consumer point of view, more so than the managed point of view. The ins and outs of how to hire and what to expect and how to negotiate with people and all of those kinds of important things, because it is a big responsibility. It is a full-time job. And whether it's you or your family member who is implementing, managing the program for you, either way, the person has to be learned, but they also have to feel comfortable that somebody who they can speak to and be connected with has similar experiences to their own. And that's something that I don't think that care management can do, because although they're totally learned, they've never hired an aide. They don't know what it's like to be in the chair or in the situation. And doctors not giving you appointments for weeks. Of course, all these things are inevitable. I would never tolerate something like that because I'm experienced, because I know my way around. And that's what I'd like to be able to see people like myself just get involved in it. But when things come to mandatory, like I said, I kind of look at us, this population, as public with other needs. So, you know, my friends that are on insurance programs, you know, every year if they get to choose a program, they look at that program and say, what kind of services can you offer me? I'm the consumer. You know, I'm paying, my job is paid, Medicaid's paying, whichever. And so, what can you offer me in my needs of service? And in that way, you choose who you think is best suited for you. I did a lot of research before this came into effect, and you know, it was all a whirlwind as far as the MLTCs and what to do and how to navigate that, and who does what, and you know, who would be better suited. That's a difficult area to get involved with when you don't know. And so I want to see that, you know, people get notices. You know, it's one thing to say, okay, look, you have to get your medical by whatever, you know, you're going to be kicked out of Medicaid, you know, to comply, sure. And do all of the things that your aides have to do to be legal and worthy and all of that kind of stuff. I just don't want to see people telling people, well, you know what, I think that this would be great, you should do it. And, you know, basically try to go to where they're comfortable with rather than what the client might be comfortable with. I think that's very important. And I don't want to see that aspect of the control of CDPAP ever lost. Because that's, independence is the keystone of what we're trying to accomplish here in life. You know, the fact that I grow up and I go to school and I go to college, and then I get out of that and they say, well, you're on traditional aid services, so you can't go here, you can't do this, they can't drive you. All of these things, we left that all behind so we could be productive, so that we could move forward in our lives and go over the obstacles that we're all going to meet and face. And this is just another part of that phase and bureaucracy in this health organizational stuff. So, I mean, basically, that's the kind of thing I want to hear, that the consumers have as much say, that they're not cajoled into something. And please don't take that the wrong way, because many times the plans will do, and the agencies as well. I've known many that will try to get the person to do what they find easier for them, what they're comfortable with, or what their proponents of the agenda for that particular thing is. And I would like to see more input, you know, perhaps a committee of people like myself that can help current and new members navigate and make them comfortable and show them that they can do this. Because it's not impossible. It's not rocket science. It's responsibility. It's responsibility to move out into the world and live your own life the way you see fit, like everybody else. You know, if you weren't disabled and you had some kind of mental impairment and nobody knew and you didn't ask for services, nobody would come to your door saying, you should behave this way. Maybe they should, but they don't. That's not how the world works. So I just want to see that the independence continues, that the relationship between each part of the link of the networks all goes smoothly and comfortably, and that together, you know, everybody can reach the place where they're comfortable with, where they want to be. And, you know, and that to me is independence is first and all only. So that's the most important thing in in my world, not being told what to do, where to go, and when to do it. And I just worry a little bit about, everything being a little too managed. Speaking about social, I don't know exactly what you mean by having people involved in the social, but as long as there's no mental impediment, then, I think that everybody finds their own.
Well, sometimes for the social part of this is in the community to let them know with their houses of worship, what they're offering. Sometimes they don't have a connection. They haven't been in the house of worship in a while. Or if they, the other thing is what is in the community for them to socially integrate into, like maybe a senior club or something of that sort. But I just wanted to take a step back to something that Brian was saying. If there's not a comfort level, and that's something we do know in nursing very, very well. I don't know what nurses are in here, but comfort is very important. And if there's not a comfort level between you and the patient, it's not going to work. So when I was at United Healthcare, I built disease management programs for them and then went into their catastrophic management. And what I found amazing was across the country, when I was building this, because I'm a firm believer, if you don't taste it, smell it, you're not going to do a good job at it. So I always had to find out from the actual patients, what was your needs and what do you want? Everybody wanted to go home, but they couldn't afford it. So what we did is we did pilot a program that was very successful. In fact, United still does have that program, where we actually trained the family members and they paid them to take care of these people within their home. And it worked out very nicely. And the readmissions went like this because, believe it or not, we watched 3 cases. And why did I watch those 3 cases? They became a very high dollar because of readmission. And then they would catch all these things. Once we engaged the family and taught the family properly how to take care of them, and we did use nursing, and we did oversee that with the care management, because I have to tell you, in this world of managed care, a lot of times a nurse that comes from the hospital sometimes doesn't understand the community. They don't understand resources. They don't understand, how to bring those resources together. So sometimes you do need somebody to step up to the plate that does have that knowledge. That's what I'm talking about for care management. If you're going to train your family members or whatever, you might want somebody in there that does have that knowledge of how to take care of them. And I'm going to say more with like vented cases. I'm going to say more with the catastrophic cases. You're going to want somebody in there because sometimes, as much as that personal person that you have picked, they're scared to death. And sometimes, that conversation, yeah, I'll take care of you, and this, that, the other. Then they walk out the door, and then here's the first person they see is the nurse going, I don't know what to do, and they're freaking out, and this, that, the other. And the first thing you have to say to them, let's breathe together, and we will be there to hold your hand through this process. So that's what I'm talking about when you need care management. And I shouldn't use the word need, but you might want the guide of care management. Who do we get to train these people? How do I get them in there? How do I know that they got these inoculations? How do I know that I'm not going to catch something from them? Are they up to the snuff on the skills and things of that sort? Because believe it or not, it's not always easy to take care of somebody as people think it is. Oh, well, that's just a little wound. Okay. A nurse thinks when it's a wound, are they a diabetic? Are they hypertensive? Is it CHF? Is it this, that, the other? I mean, my head's always going like this and trying to think when I'm bringing that plan of care together, make sure that you take your temperature with the sugar. Are we having a sick day management? Are we doing this, and this? Is somebody to teach that to somebody, though, that's going to take care of somebody in the home That makes the difference. And why am I saying something of this nature is because wounds become a big thing in the home, especially in the population of FIDA and MLTC. That is a big concern when we even hire agencies to be in there. Because one thing I do teach nursing in care management is if something doesn't change in 7 days, and you're telling me that's the same size when you walked in the door, you better get a wound care specialist, or you better take them to see a wound care specialist, because this is not working currently. So we would have to bring that knowledge one step further, is for you, whoever you're hiring, to take a look at these things. Because remember, it may not be a nurse taking care of that wound, or you may have somebody that's a lay person that you're hiring to do this. So you want to bring that knowledge to the table. But for everyday care or whatever, that's different. And you can train somebody, but the thing is, I'm going to tell you right now, you better have comfort level with the person that's trained, because you don't want somebody, put in here. And do I see that as a nurse? Yes, I do see that as a nurse, because sometimes I have to say, let's all take a deep breath, step back, and pull an aid away from somewhere. Because when I'm building programs, I spot check, because you know what? It's my name when I'm out there building these programs. And when we're out there training nurses to oversee different things, these are things that we want them to look at. Because a lot of times, you know what? It's not till you get that phone call from the state that the aide, but because the nurse, well, I was in the house and things looked okay. So things aren't okay. Because, sometimes you have to look at the body language and say to the patient, because everybody always wants to be there when the aide is there. Sometimes I say to the nurse, you might have to tell the aide to step, how's that going? How's things going? Is there anything that we can do? Things of that sort. But also, when you have a personal, in the CDPAP world, you have to have that comfort level, but you have to have a trust level too. It's a whole different world, because these are the eyes and ears that sometimes when we can't speak or act on our behalf, this is the person that will be acting on your behalf. So that's why you do have to have a trust level between the patient and whoever they choose to be their team. And sometimes you might want to have care management once in a while to come in and take a look or offer something of that sort. But if you're able to do this all independent, believe me, healthcare is all about as independent as possible, because the big models out there are self-engagement, to engage in your own care, and to come to us when you need us. So that's what they're teaching out there. The difference of this model is you are able to hire your own team, and that for you to engage. But the thing is, the knowledge may not be there, so that's why I'm recommending that they have care management. That's the only time.
Well, that's fine and good. I agree, yeah. There's a lot of things that can happen, and there's things we all don't know. I certainly understand that. I've seen many things like that go south pretty quick. But it's for referral sources, for the ability to call up and say, hey, I need a hand stroke. All I can say as far as the people you pick, though, is that, on traditional care, I had some people that, you don't want in your house, believe me. Worse than that, they don't want to be in yours. Many years ago, I had a woman come in for 4 hours a night, and she'd come in, change her clothes, and lay on the couch. And she told me, you want to go to bed? Let me know. That's my job. Okay? And, she didn't last too long. But those are the choices when you call an agency and you say to them, hey, I need somebody. They're going to try to find the best person available. And a lot of people are not as they seem. So that's why we have to be careful too, because we have to have everything checked, make sure that you're going to show up tomorrow, because if you don't show up tomorrow, I'm in debt. And that's all well and good. But, I had to navigate this world a bit on my own, and, found it fairly easy to do under under most simple circumstances, most complex circumstances as well. If somebody wants help, that's fine. I'd also like to see a database of people that want to work for CDPAP, a pool. And if they wanted to join a database and they wanted someone to call them, then they could. Most of the people I know hire people they know. Why? Because they know them. I put ads in the paper. I've done it millions of times. And I'll get 100 phone calls and 5 show up for the interview, and hopefully 1 or 2 are good. And they connect and they understand the needs, accept the responsibility, and do their jobs. And typically, all of my people, even in traditional care, were with me for many years at a time. Either they worked or they didn't work. And either there was a connection or there wasn't. And, you're going to have that everywhere. And I totally agree with the fact that you should be able to ask for whatever. And as far as, telling people what's in the community, I think it's great. If you have someone to call and you want to know about things and you want information, that's great. I think that should be available as long as it's not forced upon. That's pretty much it.
Questions?
To me, I think the biggest thing and the biggest worry that most of our consumers have is an invasion. And it's the case managers that are out there can realize that it's not one size fits all. Okay,
Right.
There are some consumers on my program that may welcome the extra assistance and finding out about the social things available to them and so forth. But there are many people on my program that don't need any help at all. In other words, they're fully, they have their social life going on, they have their job, they teach at religion school, they have a very full day. And that case management, to them, is an invasion. Somebody stopping by their house, once a month or whatever, it's an invasion to them. But once again, then other people, some, maybe an elderly person that's really having a hard time navigating things and understanding all those things she's getting in the mail, even though she's self-directing, she might need a little help and appreciate a little help. So I think that's the biggest thing, to realize, that they all don't need it. Everybody does it. It's not one size fits all.
Now, what agency are you with?
From the Long Island Center for Independent Living. We're an independent living center. We're only an F5 for CDPAP.
So the recommendation in that situation is I would let the members of your organization know that it is not mandatory. And the recommendation when you get with the health plans, and again, I'm going to be honest with you, this is new to the health plan side. This is new to the MLTC and the FIDA world. Care managers in history are either social workers or nurses. They're not business savvy, so they're always out there and they want to help. And this is the first time in history we have to say no. You have to say, if you need us, we are here. You can't say this is mandated. You can't say that you have to. You cannot use those words. And that's why when we train care managers, what we try to teach them is this. Explain the program, but tell them what your role is. Your role is that you can vanish from this, or you're a guide. That's it. Or in the guidance, do you want to see me monthly? Because then you do get some of the people who want that social interaction. They don't care who's coming in the door, so that's an added person. But for your members, I definitely would tell them that this is not mandatory, because I know that's going to happen. out there because care managers just, they have that mindset, you need us. We have to be there. And they don't understand that it's not, so sometimes the health plan has to maybe get a little slap to say, back off a little because they're on this program and the family doesn't need them. Invasion is a terrible thing. And you know what? In this organization, world here now, we really don't know who is who coming through the door. So an added person to some people adds stress, which puts onto the body, which makes them anxious. And I tell nurses and social workers that you have to be aware of what you say to the consumer and what their rights are when you're explaining this program. And you might want to say that word, I'm going to vanish, or I'll be here to guide. Whatever your choice, it is your choice.
You may have in my mind put up the flag. There needs to be that in my mind. That's someone that God managed my kid for me. You might want to come up with a new name because when I do kid management, I envision someone coming in my home and starting managing my kid. And I know that's not what you mean, but when you say those words, that's what pops in my mind. Someone coming in my home and gonna manage my children, so you might want to come up with new ideas.
Did you get that?
I think what he's saying to me is someone coming into his home and managing his
What he's
care.
saying is the title care management suggests that someone's coming into his home to manage his care. He already manages his care, so you might want to come up with a new title because it's not.
Believe it or not, it's CMS's title. The care manager came from CMS.
Yeah,
That's where it came from. And just to your point, when I was out there as the nurse and how I got into the business side of this, I was a financial analyst before. And and before that, when I would be out there in the field and the HMO managed cares, Medicaid would be saying, no, you can't do that. I'd say to the medical director, I went to school for this. Laws were made to be broken, especially contracts. Now let's go through the contract here. And I used to say to the medical directors, oh, is this really tell the patient to manage their care because nobody cares? And they used to get mad at me for saying that. And then it was funny that I came to the managed care side. But I always would have these fights with the medical directors to say, you know what? Let me show you the whole picture because you're just focused on a benefit. Get your head out of the benefit, get your head out of the computer, get out of there. Let me bring you into the patient's home and all the family members that are there. So it was always a struggle and always a fight. So when this came into play here, this was exciting because it was finally, we're getting it in New York State. And I'm not even from New York State and hoping this comes to New Jersey because when you have yourself managing your care and you're responsible for all this, people last longer, quality of life, and in their home in a better place. versus somebody who looks into a computer, well, this is your benefit, and this is this, and you just sit there sometimes and you like, your head goes, and meaning, it used to be like, and I used to go like this when I was on site in the hospital going, please don't make me come to that office because I'm gonna have to really hurt somebody, because it used to be the benefit, and that's all they would say to me is the benefit, the benefit, the benefit. And I'm trying to explain to them that you can break the benefit, you can borrow off this, because guess what, in their lifetime, they're not getting this. So let's go do this, 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 and this. And you know what, sometimes at United Healthcare, they listened to me, and sometimes they didn't listen to me. But what I'm trying to say here is this. Yes, managed care is a scary word. It is a very scary word. But I'm seeing better results, though, here in New York, especially building and being out in the community with this MLTC, and now building up for this FIDA. The result is we had to teach the players how to do this differently, number one. Because remember, nurses aren't used to that nursing home patient, because they have to be nursing home certifiable. And at the same time, bring all their needs together and keep them in the home safe and secure. And that is their job. And they'd be like, okay, this is what we're going to do. And you're like this, you're not going to tell them what to do. You're going to make suggestions with their family and all the people what to do. But you cannot tell them what to do. And this is the first time ever that this is exciting, especially for this program, because guess what? Now they really can't tell them what to do. They can serve as the guide. And that's the rule. Is that a question back there?
Yeah. Initially, how are you approaching individuals, like, because you said that there's a fear of, individuals coming in and taking over your life. How do you first approach a consumer or member? I don't know how it's guys, but
Oh,
how are you pitching this right off the bat so they'll be more open to it?
so that I don't know if you were here, I'm a consultant that has built programs, but what I train to do is in the beginning to teach care management, that they go in and explain to the member, and that's what we call them, we don't call them patients in this world, the member, and also if they have a primary caregiver or a power of attorney, that they explain the program to them. Now, I am going to tell you that in some health plans, they use that word, you have to have, this is it, I'm your care manager, this, that, the other thing. They're not really allowed to say that, though. So what we're trying to do is explain, and they're going to get zapped eventually. That's going to come into play next, because you got to remember, as programs roll out, that's when we find out what the glitches are, and it's glitches of how they present and the words that they use that need to change in this environment. And when you have things like that out there, when they use the word, this is mandatory, you have to, you need, that's when the consumer needs to come back to the health plan and say, and meaning not a confrontational word, because remember, it's a learning experience as much for both sides, that you come back to the table and say, you might want to talk to your care manager, because they just told one of my members, or told my family member today, they have to have this, and we don't have to have this. So it's new. They're not allowed to say it. Is it being said? Yes, because I'm hearing that it's being said. So that's the difference. But bringing it back to the health plan, because that is, in fairness to them, that's the only way we're all going to learn. And it is, and that's why I did say, make that suggestion about collaboratives, that you bring everybody in the same room to say, how is this working, and how's this, and what's happening. And this is where you can be honest, because when I built something called the Patient-Centered Medical Home, that was the first time I ever did something as a collaborative, and I did that for Emblem Health in New York. And I have to tell you something, in the beginning, the first collaborative physicians, I mean, they were spitting and yelling and this, that, the other. By the fourth collaborative of that, it was the most beautiful thing, because we worked it out through 2 years of building this. That the physicians were able, the patients were able, everybody spoke. Because in that room, it was all the stakeholders, because a lot of times Health plans forget, the stakeholders really the members. It's not the physicians, it's not all these people, it is the members. And that was the difference, is we brought the members into that room, and they spoke the best about the program. So that's why I'm really suggesting, and the organizations that work for the state, I would suggest that to health plans, is let's do a collaborative, because that's how we're gonna work this out, and you're gonna work it peacefully out. Because usually when you're within an organization, it's pretty much like 1 to 2 or 3 health plans that would be involved, and I would just make that suggestion, and even if you put the same health plans in the same room, it works to say, we want this to work, but at the same time, I don't want invasion on my privacy, and this is what the law says, and this is what we need to do, because you know what? This is not a perfect world, and healthcare is not a perfect world, as we can see, and the only way we learn on this side is just as much as you will be learning, is if you tell us what we're doing wrong. And that's fair, and I believe that's fair.
I can't mean, think more of how many people of case managers have a disability.
How many people case management have available?
How many case managers have disabilities?
Oh, you know what? I don't know that.
That I know.
That I don't know.
What do you? I'm not looking for number. Putting out idea that maybe that would be only something that they need to look at.
They need to look at the higher the disability
Because-
case manager.
Yeah, because it was it could be more of a fear than some many it would be on another level.
Can you say the last word? I didn't.
Level, another level.
Oh,
Yeah.
on another level.
Because if I'm disabled and I'm a case manager, I may be able to relate more one-on-one than someone that's not disabled.
That is an idea, but to take a step back, in fairness to the health plans, they would have to have an RN as the care manager, because that UAS is the assessment that they use, and the state is saying that must be filled out by an RN, and the care plan that goes with it in the state of New York has to be done by an RN. So if they hire, now I do know nurses that are disabled that are doing care management, but is that the norm across the board? No, that is not the norm across the board. And remember, in this case scenario, you're using them as more as the guidance, if you want them. And sometimes, I'm going to be honest with you, with care management, they may not have the knowledge that you even need, and you might have to say, you know what, we want another care manager, and guess what, in MLTC world and FIDA world, you have to give it. and you can change it as many times as you want, that's the rule. So if this care manager that you're getting doesn't meet the needs, you can say, I want somebody who has the knowledge to guide my family for this care. And they would and you know what, remember, you're doing your hiring, you're doing whatever. That nurse pretty much has to come through the door with a little bit of a certification or something of that to say, guess what, I'm certified in this, let me see how I can help you. So, but are they disabled, the nurses? I don't know. But you have to remember the health plans, in their defense, they have, you can't keep hiring and hiring because as much as, you have these staff, there's constraints of that staff that they do report to the state about how much money that they're spending on that. Oh, sorry.
It's okay. I'm listening to this, and I'm thinking, this is what they told us about OPWDD when they went to Community First. This is what they told us when they went to the deinstitutionalization model for OMH. And this is what they're telling us again, that it must be a medically certified person because medical knowledge is the primary focal point of coordinating care. I disagree with that. I believe independent living's been in place more than 30 years. We can be as effective in helping a consumer make decisions about managing their own care than a nurse can be. Yeah, the nurse has got to fill out the form. That doesn't necessarily mean that the nurse has to do all the work. How many times have we been to a doctor's office and a physician assistant has been in to do the visit? And the physician assistant fills out the order, and then the doctor comes in and shakes your hand and says, hi, how are you? If he's got the time, or if you've got that kind of practice, puts his stamp and his seal on it, let's wake up. How many times have we dealt with a professional practice where it's been the lower level people doing all the work in the professional practice, and the lawyers are going to come in and supervise that and put their stamp on that and let it go? Why can't there be peers and people with disabilities on teams as part of that process in this management?
You can be. Believe it or not, every health plan in MLTC and FIDA has to have a consumer board and go call up whatever plan that you go to. I would go like this, I want to be on that advisory board.
Yeah, nice. And my apologies if I'm
No,
challenging you a little bit here.
no, you're not challenging me, that's a great idea.
How nice. The volunteer consumer advisory board, that's where we'll put the consumers.
Yeah.
We won't put the consumers in a place where they might be able to be employed to do that job or to be able to get training and supports. I mean, I have this argument with WDB all the time. I believe that there are people who are OPWDD clients who could be better Medicaid service coordinators, MSCs they call them now, than a lot of the people they send out now. But this ends up being, someone with a social work background and specific training's got to do this. But guys, come on. Let's have the model be what the model is. Consumer-directed personal assistance isn't just an interesting facet to plug into a new care model. This is being able to say, the person who's going to understand the confusion of these families most is somebody who stood in it and done it. Am I right, Brian? Because I know you're nodding your head on me.
Absolutely. Well, I don't know your name back there, but when you talked about red flags coming up, I mean, yeah, and I've been told a million things by Medicaid, and I know in the back of my brain, I'm thinking control. They want control. They want to be able to come in and tell me that they're certified to tell me how I should best live my life. And what I also know, that when I have people come over in that capacity, most times, and I don't care what degree they have, they have no idea what my life is like, what my needs are, and they're going to come in there and start on Medicaid since I was 16 years old. I've been on home care since I was 17 years old. And I've had lots of fights with lots of people over language and what they say it is versus what it turns out to be a little bit later. We have to make sure that language does not get involved in here that allows them to change the mandates later or to put in some fine line at the bottom saying that they can overrule anything you want. And I totally agree with what you're saying, because I've lived it, I've seen it, I've fought it, and, you know, I would, if it wasn't for this program, I'd probably be either dead or insane by now. And so now I'm only one of the two.
Can I make a suggestion for you there? Okay. In this world now, we have to learn to think out of the box. And that's my biggest thing is always, and something you said struck, when I built the patient-centered medical home, you know how many Medicaid patients came to me and said, I don't have the skills, I don't want to work, this, that, the other thing. So, believe it or not, we had two were schizophrenics that we got back on their medications, we got them a job, this, that, the other thing. And you know how that happened? In the advisory, we put together building some of their skill sets so we could put them in the community. And that came from mental health, just building that together in the collaborative. There's so many people, you know what, I think sometimes you're afraid to ask or whatever. So if you had come to the consumer board and said, you know what, if you'd like to learn, and I'm going to just use computers as because a lot of people would love to learn how to use computers. We use the Brooklyn Public Library, which belonged to the people anyhow. And we went in and we taught classes. And then the other part of that, what we did too was we got them a Gmail account, but also taught them how to use their patient portal. And at the same time, we gave them something to do during the afternoon for the elderly population, but we got them back, and two of them, into the workforce down in Brooklyn, that they are now doing jobs doing data entry. So these are suggestions when you are on these advisors, bringing that to the table to say, you know, can you work with the community to bring this together? Because you know what? These are things in the Medicaid world under government products you can do. And there's a lot of people out there that want to offer their skills to help people. And it would all be, in the beginning, volunteer, but we got them enough to get them enough that they could get tuition to get into workforce, and they're both working doing data entry.
I understand the creative nature of thinking outside the box, but I was just listening to the previous question, and this is something I've done as an advocate for over 20 years. Every time someone comes and tells me, oh, here's a new model, I'm going to make it more efficient, what I find out is the model is run by somebody who has never sat in my shoes a day in their life.
Right.
Ever. An RN is going to come in, and I live in Buffalo, New York, by the way. An RN is going to come in and tell me, there's only 2 or 3 inches of snow on the ground, you'll be okay. I had an RN come in to do a home health assessment on me a few years ago. Said exactly that. I went, have you gotten in a wheelchair and gone out in Buffalo when it snowed on day 2? Has that ever occurred to you? Because what they'll do is they'll give us a paratransit voucher or a bus voucher in order to be able to go to a bus or a therapy appointment. When once you hit October, the likelihood of you being able to safely do that drops from 70% to 30%. The trained RN, the one who's supposed to be able to fill out this form and put their name at the bottom, doesn't know a lick about that.
Understandable 100%.
So I'm going back to that question and saying, yeah, do I want the consumer advisory councils to think outside the box? Of course I do. but I want people with disabilities to have full involvement in this process.
Thank you.
And they will. They do have full involvement
No,
in the process.
If they're in an advisory board, and that's where we think in the model we're gonna stick them,
They were
I'm gonna
advised.
agree to disagree with you on that point. Because I'm gonna say we've gotta go
You don't
beyond that.
have, no, what I'm saying is, it's not mandatory. It's if you want to go, there are consumer direct advisory boards to the MLTC, and there's also there's gonna be downstate for the FIDA.
I want people with severe disabilities to engage in this program and volunteer to be part of this program and see something that is beneficial for them. They have to see somebody at the top of that program that they trust and that they understand. Because I'm going to tell you, I am excruciatingly skeptical of any time somebody tells me I got to deal with an RN, a physician assistant, or a doctor. Because I get a doctor to sign a note that says I need gold-plated sheets for my medical condition. I did this as a medical school, as a lesson to medical school students about their role as gatekeepers. I'm excruciatingly skeptical. Okay? And I respect registered nurses highly. Their training and their commitment, but I'm skeptical. So when someone comes and says, well, this is the new model that's coming, hey, I appreciate you spending time with us, because what this tells me is, now I gotta do more. Because now, not only do I gotta go look at those consumer councils to make sure that they're properly constituted and operating and thinking outside the box, but then I gotta go into this model, and I have to create the next step.
Oh, can I just
Sure.
make a comment as well? So my name is Portia McCormick, and I'm from a plan, Gilman. We have an MLTC and a MAP, and we're going to be a FIDA soon. So we're preparing, and my understanding is, and we were actually just having this conversation with the Medicare rights people next door, is interestingly, in the MOU and the readiness review for FIDA, it doesn't say what the qualifications are of a case manager. It just says what mix of professionals, including the consumer and a participant ombudsperson, will be part of that interdisciplinary team. And so my question is, I was curious as to, okay, is there going to be like a response from the independent living centers? Because I think that's where the participant ombudsperson could potentially come from. You know, consumers who are active with, in the disability networks, they are the right people to be the representatives. If the consumer wants and needs it, it's absolutely the consumer's choice. The consumer may be able to speak on their own behalf, obviously. And but nobody seems to know, whether an RFP is going to be issued, and nobody does seem to know. I was trying to get the level of detail.
So when I was here from the beginning, what I did explain that this is, but the health plans have to be careful about what they say, because this is by no means a mandate. By care management is not mandated. That you always look to them if you want as a guide, or ask them to vanish to you come in and do another UAS on it. That's the rule. That you can't mandate care management at all. They cannot interject in your care. You have now chosen to direct your own care. But we're here to help you if it's needed. That's how it is. And it's not, and for the terminology, it wouldn't be case management, it would be care, because a care manager oversees a case manager. Because remember, case is an episode of care.
There isn't that, I think they're thinking about certified home health agency type parameters versus FIDA, which is much more.
I was the one who wrote the one that got the 100% for the model of care for one of the clients. So
I don't see that we have that kind of restriction. That is that, yes, it's true the RN is doing the uniform assessment.
Right.
But after that, plans are going to be able to determine who among the interdisciplinary team will be a case manager, and obviously the consumer is an active.
Correct, but what we talked about before, if you were in
Yeah,
here,
I'm sorry,
we
because
did,
we
we went
came
into
into-
that already, but
Mhm.
when they come to the home, it has to be an RN to do the assessment.
Yes, for the uniform assessment.
Right,
tool.
that has to be done by our RN, that there is no deviation from that. If I ask, when you come back, you might not want to see that care manager to the next time, or that person who came in the door to the next time, if they are the care manager or whatever. You might want to see the social worker. You might want to see the
What I'm
pharmacist.
saying is plans have the option, the person who does the UAS may not even be part of the interdisciplinary
Correct.
care team.
Correct.
They're going to hand off their professional assessment, but then another team could potentially be pulling together with the consumer what the actual service plan would
But
look
don't
like.
forget, this is upstate to an MLTC world up here, that's a little different. So we have to be careful about that too, about the difference of, there is a difference too, because MLTC does not have to follow that. Fight is only down, you know, in the Westchester, in the city, Bronx, in that area. We did talk about that in the beginning, that, you know, the person who's assessing them, you may not want to see them, but you might want to see the social worker. You might want to talk to the pharmacist. You might want to talk to this person. Ask them for that. That will be your contact person to call. You might just want a phone call. You may not want them in your home. That's great. But they are there for you if you need them. We don't want them to think that the plan has disappeared on them. So that's the one point that we made. It's going to be up to the individual plan of how that they decide what they're going to do with the case management piece of this, of how they run their care management teams. That's just, there is no set rule. But what I do suggest always, though, is like this gentleman had talked about before, if somebody doesn't know my illness, and I don't like my score on my UAS or my SAM, or, you know, well, UAS went effective on October 1st, so Mary, don't talk about the SAM anymore. Guess what? Bring somebody else in the door, because you know what? The second set of eyes might see this a different way. Because remember, not all nurses know everything. And how they perceive the answers. And I always take the pain question, and the other one that I used to go crazy about in this assessment world was, how could you tell me that they have 2 hours of home health aid a day, or 4, let's say, that they live alone, but they need verbal cueing. So I always go like this to the nurses, and I am a wise ass once in a while. I will say to them, does the fairy come in between to tell them what to do? Because my background is I worked at the health plans. I worked for United for a very long time. All those medical directors, they called me Mean Mary, okay? And the reason being is because they would talk benefit. And this side of the head would always be talking finance, this would be talking quality of care, because I was a financial analyst before I was a nurse. And I'd be like, take the benefit off the table, doc, because I'm here with my team, and this is what's going on in this home, and this is what's going on in the hospital. Whole different world than what you're telling me what's in that computer. Because let me tell you something, don't be zapping me and calling me when they're back in the hospital, because I'm gonna tell you it's a guarantee, because you're not listening.
Well, you know, what I'm really responding to, though, is, the consumer's perspective and right, in terms of really being actively engaged. And I don't know, I might be like an eternal optimist, but I think that there's a real opportunity with FIDA, especially if a funding stream comes through to really direct money to the independent living centers to be able to provide, very involved activists as participant ombudspeople. I'll be honest with you, from the plan point of view, that's what we're hoping, because we want to be able to partner with community-based organizations to really work on issues together. We don't
That's what
plan.
we said before. You weren't here. This is what my suggestion is.
Never mind.
Okay,
I'll just go.
so one thing that's very important with this, because it is new, is to run collaborations.
Right.
And when I did Emblem Health's patient-centered medical home, and the biggest thing was amazing. The first collaboration, doctors, everybody's fighting. By the fourth, it was a room full of happiness, because you know what? Everybody brought to the table what was not working. And when we built this out, it was amazing, because you know, doctors were happy, patients were happy, families were happy, because you know what? They understood. We had to bring this all together. When you talk about a whole person, you're talking mental, you're talking physical, you're talking social, you're talking in their houses of worship, their culture. We have to bring that together. And people don't understand that until you had this collaboration. But when you collaborate, and this, when we were speaking before, because this is where you can't claim the health plan if you don't tell them. And I said, and to call up the health plan and go, you know what? No, because it's new. And in fairness to the health plans, we don't know, you know, I know we're responsible a lot of times for what they say, but sometimes this is a learning curve. So bring it back, and you know what? Health plans love when you bring that back, because they do work on these things with their quality and quality improvement. These things do go to medical management, and things of collaborative come back to the table. So that's why I'm really impressing, upon, because of the consumer board that has to happen with your MLTC or the FIDA. I am just recommending to be the voice, because I gotta tell you, things happen, and if they run the collaborative, you should be the first ones at that table to be there to talk, because you have great ideas, and as the consumer, we want to hear that. But you know what, to keep it in the silo, I spoke to the state, and I spoke to this, you know what, the health plans hate when the state's coming, because you know what, it's the telephone game. By the time the state got it, the story's 10 different times different. And then when it comes to the table, versus when somebody calls me, I'm gonna send somebody out there, we're gonna sit together with all the people involved, and if I gotta remove somebody out of that home, that's how that works. So with this, in the consumer direct world, this is new, and the health plans want a vision. They want to be the best at it, and they want to be able to help you and give you that guidance. So I'm just saying, pick up the phone, speak to the clinical director, and I bet you'll see a change of how this was perceived or presented in the community. I really do. I know there's frustration with nurses. I have frustration, and I teach nursing, and I have frustration sometimes, but it's just, it's a learning curve. So that's my recommendation for you. But I just think there's a lot of knowledge in this room and great ideas, and I think everybody's going to welcome. So it was, you know, and I just think please always be open with your health plans. Oh, I'm sorry.
One comment. Being an advisory board and being at the table every day and working with people, not the same. When you're on advisory board, you can advise. That's it, right? But when you are working one-on-one with a person, you have a lot more impact. So, hearing advisory boards are mandated, but that's good. I'm not putting that down, but it's really not the same as working day in and day out with people that are doing their work.
That's a good point. That's a good point, day in and day out of, versus the advisory versus the one-on-one. And I always believe the benefit of the doubt. And you know what? I learn every day. I'm not a perfect nurse. I'm not a perfect consultant. I'm not a perfect professor. And I learn from everybody, and I learn something new every day. And I just love being in the community because when, like I said, I have to smell it, see it. People can't tell me. I got to go out and hear from the people, and that's how, and I've built some great programs that sustain for many years. And I think that's because you went out there, the consumer. And right here, I don't know your name, sir. Todd, I just think you bring a lot of value to this table, and I just think that, you know what, you need to keep pushing and advocating because I hear that strength behind you. But the other thing is, I heard you today, but I think whatever health plan or whatever organization that you're in, you have to bring this to the health plan, and I can almost guarantee you will be heard. I will, because health plans do listen. I thank everybody for your time today. I wish you a great afternoon.
And I'll take that up with the advisory board and have somebody